Okay, let's unpack this.
Let's do it.
If there's one procedure that it truly feels like the perfect intersection of sports medicine, pure biomechanical engineering, and just sheer high-precision surgical technique, it has to be the anterior cruciate ligament reconstruction.
It really is. And today, we're not just talking theory.
No, absolutely not. We're moving way beyond the 101. We're essentially scrubbing in today, diving right into the operating theater. Our sources lay out this incredible surgical blueprint, a real surgeon's guide to doing this, with the hamstring tendon autograft, the HTA.
That's exactly right. This isn't a theoretical debate. Think of it as a critical review of technique. Anyone in orthopedics knows the evolution here, right? We've gone from these big open surgeries to incredibly refined all arthroscopic techniques.
And the decision points are everything.
They are. The graft choice, how you fix it, and maybe most importantly, the surgical technique. That precise anatomic placement. That's what decides whether the patient gets a stable knee and long-term function.
So our mission today is to really synthesize that clinical consensus. We're going to dissect the meticulous, you could say non-negotiable, steps that you need for a predictable and successful HTA reconstruction.
Exactly.
It honestly feels like we're prepping for a really complex rotation, just scrutinizing every single step that goes into what is an incredibly high-volume procedure. And that first choice, the graft itself, really sets the stage for everything else.
It absolutely does.
So let's start there in section 1. Let's get into the great graft debate. Why did the hamstring tendon autograft, the HTA clips, what was for so long the gold standard?
Well, that whole shift, it's really driven by this ongoing quest for the ideal graft, the perfect biological and mechanical replacement.
And what does that ideal graft look like? What are the criteria?
We look for 5 non-negotiable things. First, it has to be biologically active. It has to be viable tissue. Second, it's got to be easy to harvest with minimal donor site morbidity.
Meaning you don't create a new problem by taking it out.
Precisely. Third, it has to match, or even better, exceed the strength of the native ACL. Fourth, it needs to incorporate quickly into the bone tunnels. And finally, it has to allow for really rigid fixation so we can get the patient moving right away.
Okay, so on that first point, biological viability, the whole autograft versus allograft debate seems pretty settled for most primary reconstructions, doesn't it?
Oh, for the most part, yes. In an athletic population, autograft using the patient's own tissue is almost always the preference.
Wow.
The literature is pretty clear on this.
And the reasons are?
Several big ones. It's immediately available. You don't have to order it. It's cheaper than a processed allograft. Biologically, it has a huge head start with faster incorporation. And of course, you completely eliminate any risk of disease transmission.
Which brings us back to the old champion, the patellar tendon autograft, or PTA.
Okay.
For decades, that was the benchmark. So if it was so good, what was its Achilles heel? What made its popularity drop off?
In 2 words, donor site morbidity.
The harvest site.
Plain and simple. Mechanically, the PTA is a fantastic graft. It's robust. But the price the patient paid for us taking that central third of their patellar tendon, you're taking bone blocks from the patella and the tibia, that became the major drawback.
So what were patients complaining about?
We saw this consistent pattern of both short and long-term issues. The biggest ones were persistent anterior knee pain, and especially pain with kneeling. A measurable loss of postoperative extension was also a big one.
So the knee is stable, but the patient can't kneel down for the rest of their life.
Exactly. And from a quality of life perspective, you have to ask, is that really a success? It's a huge trade-off.
So we pivoted to the hamstring tendons, specifically using the semitendinosus and gracilis to create a quadruple strand construct. And the sources, specifically table 48.1, give us some hard numbers on why this isn't just an alternative, it's actually mechanically superior.
This is the data that really shifted the consensus. Because when you create that quadruple strand HTA, you fundamentally change the mechanical profile of what you're putting in the knee.
Let's talk numbers. The ultimate tensile load of a native ACL is what?
It's rated at about 2,160 newtons, which is strong.
But the 4-strand HTA?
It's almost double. We're talking 4,090 newtons.
Wow.
So you're not just replacing a failed part with an equal one, you're putting in a structure with a massive mechanical safety margin. It's like you said in the outline. You're replacing a garden hose with a fire hose.
And that redundancy, that extra strength, it has to help with rehab.
It's huge for rehab. It means the construct can handle those high peak loads you see in early rehab and return to sport far more effectively than the native ligament ever could.
And it's not just the failure load, right? The stiffness is also a big factor.
It is. Stiffness is that resistance to stretching under load. A native ACL is around 242 newtons per millimeter. The HTA construct, it's way up there at 776.
So the knee just feels more solid.
It feels instantly stable. A stiffer graft resists that cyclical stretching that can lead to laxity over time. And there's one other small point. The cross-sectional area of the 4-strand graft is actually a little bit bigger than the native ACL, which is good. It gives you a larger surface area for that vascular ingrowth and biological incorporation we're going to talk about.
Okay, so the PTA had that nice bone-to-bone healing, but the HTA just comes out of the gate with this massive mechanical advantage.
Yeah.
So what are the trade-offs? What do we accept when we choose HTA?
Well, the trade-offs are mostly transient, which is the key. Patients will have some discomfort at the harvest site for sure, usually for about 6 to 8 weeks. And they might notice some weakness with really deep knee flexion, like doing hamstring curls.
But that usually resolves.
It usually resolves or it's compensated for over time. Early on, we did see a bit more initial anteroposterior laxity with the HTA compared to PTA, but we figured out that was a fixation problem, not a graft problem. And modern fixation techniques have pretty much solved that.
So you're trading a few weeks of discomfort for a lifetime, free of that chronic kneeling pain.
That's the trade. And for most patients and surgeons, it's a trade worth making every single time.
Okay, let's shift to the biology of what happens after surgery. We use this term, ligamentization, which sounds almost like this magical transformation. But as we get into section 2, the reality is, well, it's a lot more complex and, frankly, a bit sobering.
It is. You're taking a tendon, which is this tough structure designed for pure tension, and asking it to become a ligament, which has to handle these complex multiplanar loads inside a joint. That process, ligamentization, is the remodeling the graft goes through.
And we break it down into 4 phases, right?
Well, you do, at least conceptually, for planning rehab. You have the acute inflammatory phase right after surgery. Then comes revascularization, where the graft gets a new blood supply and becomes alive again. That's around 6 weeks. Then you get cellular proliferation, where fibroblasts start multiplying and laying down new collagen. And finally, the longest phase, collagen remodeling, which can take up to 2 years. That's where the collagen fibers align under tension and the graft gets its final strength.
It sounds so neat and orderly when you lay it out like that. But what's the giant caveat we have to attach to our understanding of these phases in humans?
The massive caveat is that almost all of our really high-fidelity biological data on this process, the cellular changes, the collagen types, it's all from animal models.
So sheep and goats.
Mostly sheep and goats, yes. So the true in vivo process in the human knee, especially how fast and how completely this transformation happens, it's still not perfectly understood. We see the successful biomechanical outcome, but the subtle biology is still a bit of a black box.
We do have some human data, though, that shows a really critical difference in how the graft heals depending on how we fix it. The difference between true integration versus just being enveloped.
This is fundamental to why fixation strategy matters so much. When we use strong aperture fixation, like an interference screw, we have biopsies taken from grafts that unfortunately failed due to trauma later on, and they show complete integration.
What does it look like under a microscope?
You can actually see the presence of Sharpie-like fibers. These are the little structures that literally anchor a tendon or ligament directly into the bone. And we can see them as early as 6 to 12 weeks post-op. It means a true structural bony connection is forming.
It's mimicking the native attachment.
It is. But what about when you use a different type of fixation, like a suspensory device, a button on the outside of the bone?
What do those biopsies show?
A very different story. With pure suspensory fixation, the graft is more often just enveloped by a layer of granulation tissue, like a fibrous sac. Histologically, there's often no direct integrated connection between the tendon and the bone inside the tunnel.
So it's hanging in there rather than being knitted into the bone.
That's a good way to put it. And that distinction is why there's such a drive toward aperture fixation. We're aiming for that true biological integration.
That distinction is huge. But then we get to the really sobering reality check, the one that we have to explain to every patient. The reconstructed ACL is, biologically speaking, an inferior structure to the one we lost.
That's the hard truth. We have to be honest about it. A normal native ligament never, ever forms after a reconstruction.
So what are we creating?
We're creating a very strong piece of scar tissue, a functionally robust tendon that does the job of a ligament. But its fundamental structure is different, and the most important difference is that the reconstructed ACL has no neural elements. It's not innervated.
It's dumb tissue.
It's dumb tissue. The native ACL is a smart organ. It's full of nerves that provide proprioception. They tell your brain where your knee is in space. It's a key part of that protective reflex loop.
So even if the new graft is strong and stiff, it's lost that internal alarm system.
Precisely. That lightning-fast feedback loop is gone. The patient now has to rely entirely on their external, learned protective mechanisms, their muscles, their motor control. And that biological deficit is exactly why neuromuscular training in rehab isn't just helpful, it is absolutely mandatory for long-term safety.
That biological timeline is the perfect lead-in to Section 3. Because if that graft is just starting to integrate at 6 or 12 weeks, the fixation system has to be rock solid from the moment we leave the OR.
Instantly rock solid on day 0.
So what kind of forces are we talking about? What's the immediate burden on that graft and its fixation?
It's substantial. Just from activities of daily living, walking, standing up from a chair, we estimate those forces can reach up to 450 newtons.
450 newtons, just to put that in context.
Think about the force of your body weight accelerating during a normal gait cycle. It's significant repetitive loading. And if your fixation slips by even 1 millimeter under those loads, you lose tension, the graft effectively lengthens, and that whole ligamentization process is compromised.
And we achieve that stability with aperture fixation, using interference screws to basically wedge the graft against the tunnel wall. So what's the technical key to making that hold as strong as possible?
The science here is pretty straightforward. For aperture fixation, strength is all about contact area and compression force. So we try to use longer and larger diameter screws where we can. But the single most critical factor is the fit.
The graft to tunnel fit.
The Goldilocks fit. The tunnel needs to be sized about 0.5 millimeters larger than the prepared graft.
Why not the exact same size? That seems counterintuitive.
If the tunnel is too tight, if it's the same size or even smaller, you risk shredding the graft bundles as you pull them in, especially if there are any sharp bony edges. But if it's too loose, you lose that compression that's essential for fixation. That ½ millimeter difference seems to be the sweet spot.
And what about the other major class of fixation, the suspensory devices? You mentioned their mechanical downside is related to tunnel widening.
Correct. We've seen multiple studies report a higher incidence of tunnel widening with suspensory fixation.
And the theory is micromotion.
The hypothesis is very strong. Since the fixation point is outside the bone, sometimes centimeters away from the joint line, it allows the graft to have this little pendulum motion inside the tunnel. That micromotion can cause irritation, bone resorption, and eventually the tunnel gets wider. Aperture fixation, by contrast, minimizes that gap.
Okay, let's talk about the screws themselves, the materials. There was a big push for bioabsorbable screws for a while. The idea was great, they'd disappear and be replaced by bone. But the reality was disappointing.
The clinical reality did not live up to the biological promise, that's for sure. We found that with the devices that resorbed too quickly, we often saw no new bone formation in the tunnel.
So you just got to avoid.
You got to avoid. And worse, that rapid resorption was frequently linked to local adverse reactions, inflammation, synovitis, and even sterile cysts and ganglia forming inside the tunnels. We were creating a whole new set of complications.
Which is where peak polythiourethicacetone comes in. You can see in figure 48.1, it's an inert plastic, and it's become the preferred material for many surgeons.
So what's its core advantage over something like titanium?
PEEK has been around in orthopedics since the late 90s, and it's incredibly stable. The key advantage is that it solves the imaging problem you have with metal.
The MRI artifact.
Exactly. Titanium is strong, but on an MRI, it creates this massive flare, this artifact. It means the one place you really want to see, the interface where the graft meets the screw in the bone, is completely blacked out.
So you're flying blind post-op.
You are. PEEK, because it's non-metallic, fixes that entirely. We can get a post-operative MRI and actually visualize the fixation. We can check the healing. We can see the integrity. We can look for any issues like cysts.
So it's a diagnostic tool that metal just doesn't allow for. And critically, you're not sacrificing any strength. Not at all. Mechanically, PEEK is a beast. Some research has shown PEEK screws can have a higher ultimate failure load and even double the push-out strength compared to titanium. The pull-out force is equivalent. So you're getting the best of both worlds. Great mechanical hold and clear post-op imaging.
Now, before we move on from fixation, there's a critical nuance. Standard fixation can sometimes fall short in specific patient groups, particularly females and older patients. Why is that if the HTA construct is already so strong?
It's a really complex biomechanical issue. One study showed that females who had an HTA reconstruction with standard screw fixation actually had more postoperative laxity than their male counterparts.
And the thinking is that it's related to bone quality or tunnel size.
That's the hypothesis. Potentially smaller tunnels, smaller grafts, maybe subtle differences in bone density or tissue compliance. The point is, the fixation wasn't holding the tension as well in that group.
And the fix for it, adding supplemental fixation like a staple, solved the laxity, but then it created the exact problem we were trying to avoid with HPA in the first place.
Exactly. Adding a staple on the tibia did get rid of the extra laxity in those female patients, but it dramatically increased their rate of kneeling pain at 2 years. It's a terrible trade-off to have to make. And we face a similar issue in older patients. Their bone mineral density is lower, so the screw threads just don't get the same purchase. We often have to consider supplemental fixation for them as well.
All right, let's shift gears to the actual execution in the OR. This is where the art really meets the science. Section 4 on anatomic tunnel placement is arguably the single most critical factor for long-term success.
Without a doubt.
That feeling of residual rotational instability, that pivot shift, it's almost always an issue of tunnel placement. Right?
Almost always. It's a surgical technique issue, and a lot of that came from the evolution of how we drilled the femoral tunnel.
You're talking about the old transtibial technique.
Yes, the problem with transtibial drilling was that it was inherently non-anatomic. The path of your tibial tunnel dictated where your femoral tunnel ended up.
It constrained you.
Completely. It forced the femoral tunnel into this steep vertical position. And while that vertical graft felt stable on a simple front-to-back test like a Lachman test, it did absolutely nothing to control the rotational forces. It didn't control the pivot.
Which led to the widespread adoption of the low anteromedial or AM portal technique. This was a huge shift.
A huge shift. The whole rationale of the low AM portal is that it allows you to drill the femoral tunnel independently, and we drill it first.
Why is that so important?
Because by coming in through that low AM portal, we can aim the drill guide exactly where we want it to go, right in the middle of the native ACL footprint on the femur. We can create that low oblique anatomic tunnel that's necessary to control rotation.
And there's a practical advantage to drilling the femur first, too, isn't there? Something about visualization.
Yes, a big one. If you drill the tibia first, all your irrigation fluid just pours out of the joint through that big hole. Your view collapses. By drilling the femur first, you maintain intra-articular pressure. You keep a clear, stable view, which is essential.
And the critical safety step during femoral drilling.
The knee has to be flexed to 120 degrees, hyperflexion. That pulls the back wall of the femur forward and gives you a safe margin so you don't accidentally blow out the back of the condyle with your drill or your screw. It's non-negotiable.
Okay, let's get into the numbers. The GPS coordinates for stability, as the outline calls them. After the surgery, you're looking at radiographs to confirm you hit your marks. These percentages are incredibly precise.
They are, and they're the gold standard for confirming a successful placement. So let's look at the femur first, and you can see this in figure 48.9. On the side view, the sagittal view, we're measuring along Blumensatz's line, the roof of the notch. The center of your tunnel must be at 86% posteriorly along that line.
86%? What happens if you're too far forward, say at 75 or 80%?
That's a classic surgical error. An anterior femoral tunnel is a disaster. The graft becomes way too tight when the knee extends. It acts like a brake that's always on. That leads to stiffness, loss of extension, and over time, that constant tension will just cause the graft to stretch out and fail.
And on the front view, the coronal view.
The center needs to be at 43% lateral to the lateral femoral epicondyle.
Okay, so that's the femur. Now what about the tibial tunnel? The coordinates there are just as critical.
Just as critical. Again, looking at figure 48.9. On the sagittal view, the center should be at 48% posteriorly along the tibial plateau.
And again, if they're off,
if you go too far back, more than 50%, you can cause impingement in the back of the knee and lose flexion. Too far forward, and you risk the graft rubbing on the notch in extension. And then on the coronal view, we aim for 47% across the width of the tibia from the medial side. That lines it up perfectly with the medial tibial spine.
So it's that combination, 86% posterior on the femur, 48% posterior on the tibia, that gives you the obliquity you need for rotational control. But the sources point out an even finer detail, the difference between operating on a left versus a right knee.
This is a beautiful example of just how refined the technique has become. A study noticed these subtle differences in laxity post-op between left and right knees, and the hypothesis was just brilliant.
It had to do with the screw threads.
It's the direction of the threads. A standard screw has a right-hand thread, so when you insert it, it rotates clockwise.
And in a left knee, that clockwise rotation does what to the graft?
In the left knee, it tends to twist the graft bundle slightly posteriorly in the tunnel. which is actually a good thing. It seats it in a really stable position.
But in the right knee.
In the right knee, that same clockwise rotation pushes the graft into a relatively anterior position. And as we just said, anterior placement is bad. So this tiny detail, the chirality of the screw thread, was causing a detectable difference in laxity.
And the solution was just to use a reverse thread screw for right knees.
It's an elegant engineering solution. A reverse thread screw rotates counterclockwise. So in the right knee, it nudges the graft bundle posteriorly, just like in the left knee, correcting that bias. It's an incredible level of detail.
Okay, now let's get into the OR. Section 5 walks us through the actual operative steps, turning all this planning into reality. And it starts before you even make an incision. Timing is everything.
Timing is paramount, and you have to be disciplined. The surgery has to be delayed until the knee is quiet.
What does that mean, practically?
It means the swelling is down, the patient isn't in a lot of pain, and they have nearly full range of motion. If you operate on a hot, stiff, angry knee, you dramatically increase the risk of arthrofibrosis, that terrible postoperative stiffness.
But you can't wait too long either.
No, that's the other side of it. Waiting more than 4 or 5 months is linked to a higher rate of secondary damage, like meniscus tears and cartilage damage from the ongoing instability. So there's a sweet spot, usually between 3 and 8 weeks after the injury.
Okay, and for infection prevention, the sources detail a pretty robust antibiotic regimen.
Yes, we use a combination of vancomycin and a cephalosporin before the incision. This dual coverage is very effective, and it's brought our infection rate down to less than 0.1%. We also soak the prepared graft in a vancomycin solution right up until it goes into the knee.
All right, so the patient is positioned, knee flexed at 70 degrees, as you see in figure 48.4, and we're ready for the hamstring harvest. This step looks simple, but it's deceptively tricky.
It is. The incision is a small 2-centimeter oblique cut over the pes anserine. And the reason it's oblique is critical. It's to protect the infrapatellar branch of the saphenous nerve. If you damage that nerve, the patient can have chronic numbness over the front of their shin.
And once you're in, you identify the semitendinosus and the gracilis.
You identify them separately, and you harvest them one at a time. The gracilis is usually pretty straightforward. The semitendinosus, though, that's where you can fall into the vinculi trap.
That's a great name for it. What is that?
It's a classic pitfall. The semi-T has these little fibrous connections, the vinculi, that anchor it down deep to the fascia of the calf muscle. If you just put your tendon stripper on and pull without dealing with those, you'll cut the tendon short.
And then your graft is useless.
Your graft is too short, and you're in trouble. You have to physically identify and divide those vinculi before you use the stripper to get the full 22-centimeter length we need.
That is a critical pearl. So once they're harvested, you move to the back table for preparation.
And that preparation has to be meticulous. You strip off all the muscle, and especially the mesotendon, that vascular sheath. If you leave that on and transplant it, it can lead to cyst formation later.
Then you whip stitch the ends and form the 4-strand bundle. And there's a great safety tip in here about not detaching the graft completely right away.
Yes. We leave the graft attached distally at its natural insertion until the very last moment before we pass it. This completely eliminates the risk of dropping the graft on the floor, which is a catastrophic event in the OR.
And for post-op pain control at the donor site.
We infiltrate about 50 milliliters of local anesthetic, bupivacaine with adrenaline, all along the harvest tract. You can see how that's done in figure 48.6. It provides a great block for that immediate post-op pain.
Okay, now we're inside the joint, creating the tunnels. What's the first step inside the notch?
First, you just debride the ACL stump and make sure you can see the lateral wall of the notch clearly. Importantly, with this anatomic technique, we do not perform a notchplasty. We don't widen the notch.
Because if the tunnel is in the right place, the graft won't impinge.
Exactly. We only do a notchplasty in very rare chronic cases where there are bone spurs narrowing the space.
So femoral tunnel next. We're back to the low AM portal, aiming for that 10 to 10.30 position in a right knee.
You confirm the spot with an awl. Then, with the knee in that safe 120-degree flexion, you drill a small pin across both cortices, and then you ream your tunnel to a depth of 30 millimeters, sizing it about a ½ millimeter to a millimeter bigger than the graft.
Then the graft gets passed into the joint and seated up to that 30-millimeter mark in the femur. Now it's time for fixation.
And you keep the knee flexed at 120 degrees for this. The guide wire goes in through the AM portal, and then you advance your 7x27 peak screw. For a right knee, remember, we're using the reverse thread screw, and you have to bury it. The head of the screw should be 5 to 10 millimeters deep inside the tunnel. You shouldn't see it.
Next, the tibial tunnel. What's the landmark for that one?
We aim for a spot about 5 millimeters medial to a line that connects the medial tibial spine to the back of the lateral meniscus. That puts it in that perfect oblique position. And for the tibia, we drill the tunnel to the exact same diameter as the graft for a really tight, snug fit.
Okay, we're at a final critical sequence, tensioning and final fixation. This is what determines if the patient gets their full extension back.
This is the make or break moment for motion. First, with the knee at 70 degrees of flexion, we apply tension to the graft and just lightly advance the tibial screw to capture it. This is for bundle equalization.
And then the key move.
Then you slowly extend the knee all the way to full hyperextension. This allows the 4 strands to slip a tiny bit and equalize the tension between them. Then, while you're holding it in full hyperextension, you drive the screw all the way home. Doing it this way is the key to preventing that postoperative loss of motion.
And the very last detail, the graft plug.
Yes. Once it's fixed, we cut the graft about 5 millimeters longer than the tunnel, and we take that little remnant and pack it into the opening of the tibial tunnel right over the screw head. It acts like a biological plug. It seals the tunnel, reduces bleeding, and significantly lowers the chance of forming one of those pretibial cysts. Then you do a final stability check and you're done.
So we've left the OR with a stable, anatomically perfect reconstruction. But as Section 6 makes very clear, surgical success is only half the battle. Post-op management is everything. Let's talk about the accelerated rehab protocol on Table 48.4.
It is an aggressive protocol, but it's evidence-based. And critically, we do it without a brace. The only reason we can allow immediate full weight bearing and motion is because of that rigid anatomic fixation we just achieved.
So what are the immediate goals in the first couple of weeks?
It's all about 2 things. Restoring full symmetrical extension, getting that hyperextension back, and getting the VMO muscle firing with static co-contractions.
Now, the graft is at its weakest point during that revascularization phase, around 6 weeks. How does that affect the rehab?
It means we have to be very cautious with the donor site. We avoid any resisted hamstring strengthening for at least 6 weeks to let that area heal. But by 6 weeks, we can start some gentle eccentric hamstring work, and we can usually let them start solo sports with low impact, like cycling or swimming.
And then at 12 weeks, the training becomes more dynamic and functional.
Exactly. That's when we'll start jogging in a straight line. We can begin open chain exercises like leg extensions, but only in a protected range, from 40 to 90 degrees of flexion at first. And the proprioception work gets more complex. Step lunges, half squats, things like that.
And then the big milestone, returning to sport, usually around 5 or 6 months. What's the mandatory final hurdle they have to clear?
They absolutely must complete the PEP program. That's prevent injury, enhance performance. It's a specific neuromuscular training program, and they have to do it for 30 straight days before we will even consider clearing them for cutting and pivoting sports. It is not optional.
And it's not optional because of the complication risk we're about to discuss. Let's talk about those. Loss of motion is one, but the recurrence risk, that statistic is terrifying.
Loss of motion or stiffness happens in maybe 2 to 5% of cases. And prevention is all surgical. Operate on a quiet knee, get your tunnel placement right, and tension the graft in full hyperextension. If it happens anyway, it's aggressive physical therapy.
But the recurrence risk, the chance of another ACL injury, that's the real black cloud hanging over this whole procedure.
It's the huge epidemiological challenge we're all facing. A patient who has had one ACL injury faces a shocking 33% incident
33%.
of either rupturing the contralateral, the other ACL, or re-rupturing their graft.
1 in 3 of your successful reconstructions is going to have another ACL event.
1 in 3. Compared to a normal athletic population risk of maybe 1.5% per year, it is a massive, massive risk.
And that just hammers home why that PEP program is so critical. It's not just rehab for the knee you fixed. It's preventative medicine for the whole athlete.
That is a core takeaway. That neuromuscular training is proven to reduce this incredibly high risk. It's how we compensate for that biological deficit we talked about, the loss of the nerve endings. The patient has to train their muscles to be their new, smarter protective reflex because the original one is gone forever.
And just to close the loop on complication avoidance, the other things are purely technical. Femoral tunnel blowout is prevented by drilling at 120 degrees of flexion. Pretibial cysts are minimized by creating that graft plug.
Every single step in that blueprint we walk through, from the skin incision to the final tensioning, is a calculated move designed to avoid a specific known complication. It's a procedure where mastery is really just meticulous attention to 100 small details. #tag outros.
So what does this all mean? We've walked through this incredibly calculated progression of ACL surgery, from choosing the biomechanically superior HTA construct to understanding the sobering reality of ligamentization, the engineering needs of key fixation, and the absolute non-negotiables of tunnel placement.
I think the recipe for a successful outcome really boils down to three things. First, you have to use the best material, leveraging that 40-90 Newton strength of the quadruple strand HTA. Second, the placement has to be perfect anatomic, achieved with that low AM portal technique, hitting those precise landmarks like 86% posterior on the femur and 48% on the tibia. And third, you have to lock it down with rigid aperture fixation like PEEK that can handle those early 450 Newton loads.
And when you put all that together, you get a technique that reliably restores stability and allows for that accelerated return to sport. But I think the final provocative thought, based on all this data, has to shift our focus away from just the operating table.
I agree. Given that we know an ACL reconstruction never creates a truly normal innervated ligament, you're putting in a replacement that lacks sensory intelligence. And given that these patients, especially young athletes, face that staggering 33% risk of another ACL injury, the surgery is just the entrance ticket. The real long-term challenge is aggressively implementing and maintaining neuromuscular training programs like PPP, probably for the rest of their athletic career.
So the final question for all of us is this. How does knowing the catastrophic re-rupture risk change the way we counsel and manage an athlete who at 6 months feels cured and is psychologically ready to go, even though we know their body is still carrying this huge biological vulnerability?
That's the lifetime commitment, the one that we and the patient have to undertake together.